started now. Okay. So what is so I'll try to write something new, something different that I'm doing in this one, and in this one I'm going to do very fast. I'll just teach as fast as possible in this one. Okay. So intertrochanteric fracture. Intertrochanteric fracture is it's a fracture in the region of proximal femur involving either greater or lesser trochanter or both. It is caused by first of all the sideways fall, a blow over the greater trochanter. Clinically, there is pain in the groin, inability to move the leg. There will be swelling in the region of the leg, shortening of the leg. Leg will be externally rotated, and tenderness will be there in the greater trochanter. So radiological features, you will have communication of the medial cortex of the neck, and avulsion of the lesser trochanter will be there. Extension of the fracture to the subtrochanteric will lead to will indicate an unstable fracture. So treatment, you have conservative and operative methods. Conservative, Russell's traction and skeletal traction in the Thomas splint. And operative, the fracture is reduced under X-ray control and is fixed with internal fixation device. So most common internal fixation devices are dynamic hip screw, Ender's nails, and nails such as gamma nail and proximal femoral nail. And complications, you have malunion and osteoarthritis. So treatment, so fracture of neck of the femur, it affects more than 50 years of age, whereas intertrochanteric fracture is after 50 years of age. Female is more than male, male is more than female in intertrochanter. Trivial injuries and significant injury in intertrochanter. Only trivial injuries can lead to fracture of femur. So ability walk may be impacted. The pain will be mild, whereas in intertrochanteric it will be severe. Swelling will be severe in intertrochanteric, and ecchymosis will be present in intertrochanteric. In as far as tenderness goes, in the scar pass areas it will be tenderness, whereas in intertrochanteric it's a greater trochanter. External rotational deformity is less than 45 degrees, whereas it's more than 45 degrees in intertrochanteric. Shortening is less than 1 inch, whereas in intertrochanteric it's more than 1 inch. And treatment is internal fixation always of the fracture of femur of neck. However, in intertrochanteric it can be managed in just traction. Then complication, non-union will be seen, whereas in here the malunion will be seen. So of course there will be no swelling and ecchymosis because it's not there outside, it's inside the cavity, whereas all of this it will be outside the cavity. It's severe because it's always okay. There may be impacted walking because fracture of femur of the neck is more unstable. Non-union is common in fracture of femur of neck, whereas malunion is common in fracture of intertrochanteric fracture. So injuries of the knee, you have fracture of patella caused by directed force, which leads to comminuted fracture, and indirect force will lead to striated fracture. So sudden violent contraction of the quadriceps will lead it to become two parts. It is the two-part fracture and striated fracture. So pathanatomy, the fracture may remain undisplaced by prepatellar expansion of quadriceps tendons and patellar reticuli. So clinically, there is pain and swelling over the knee. Crepitus will be there in comminuted fracture. The gap between the fractures will lead to displaced fractures. Bruises will be there over the knee, which is a sign of direct trauma. The knee will be swollen, which may lead to hemarthrosis. There will be inability to lift the leg with knee in full extension, and leg in extension there will be a lag. There is reception of the external apparatus, therefore there will be a lag. So radiological examination, AP view, lateral view, and the skyline view of the patella you have to do. Skyline is you have to bend the knee like this and see it like this. The X-ray will go like this. Okay, then treatment, you have undisplaced fracture, you have to provide a cylinder cast, and the plaster extends from groin to the malleoli. Knee is in full extension, or you can do a two-part surgery open reduction with tension band wiring and external retinacula repair. So comminuted fracture, you can do patelectomy, remove the patella entirely. So complications, you have knee stiffness can be seen, which due to intra-articular and peri-articular adhesions, the knee stiffness will be there. There will be extensor weakness due to inadequate repair of extensor upper neurosis or due to quadriceps weakness, and there can be osteoarthritis. So essential features of knee ligament injury, you have medial collateral, lateral collateral, anterior cruciate and posterior cruciate. All of these are ligament, and injuries for medial collateral is varus force, lateral collateral is varus force, anterior is twisting extension with the twisting, and posterior will be backward force on the tibia. Again, pain will be on the same side, and however in anterior cruciate and posterior cruciate it will be swelling, diffuse. So, and then hemorrhages can occur in anterior and posterior cruciate, whereas in collaterals it will be swelling on the same side, it will be there. Then tenderness will be on the same side, however in these it will be vague, and in medial collateral on the femoral condyle, whereas in lateral collateral it's on the fibular head. Lateral collateral tearing. Okay, so the tests you can do is vagus test plus 30-degree valgus test, because it is the same thing which is causing mechanism of injury. You have to put vagus test, 30-degree flexion, anterior drawing test and enlargement test will be positive, and in posterior cruciate, posterior drawing test will be positive. Okay, so dislocation of knee mechanism, there is severe injury to the knee, all supporting ligaments are torn. It is associated with popliteal artery aneurysm or bleeding. So you do reduction followed by immobilization in a cylinder cast. Surgically, you can do multiple ligament reconstruction. Dislocation of patella, most commonly laterally because it's very lax over there, but it can be anterior, recurrent or habitual. So acute dislocation, sudden contraction of quadriceps, well, knee is in flexed or semi-flexed. Patella dislocates laterally and patient is unable to straighten the knee. Medial condyle is more prominent. Treatment is reduction and immobilization in a cylindrical cast. Recurrent is excessive due to joint laxity, small patella, patella alta, high-lying patella in the shallower part of intercondylar group and genovarium. Treatment due to Hauser's operation, which is operative reconstruction. Insertion of patella tendon on the tibial tuberosity is shifted medially and downwards, and the line of pull of quadriceps also shifts medially. So then habitual dislocation is patella dislocates laterally every time the knee is flexed, and the patient is presenting this complaint in early childhood. There is similar recurrent dislocation will be there. There is shortened quadriceps. It is similar to recurrent dislocation in that excessive joint laxity, small patella, patella alta and genovarium may be seen. Then treatment in habitual is release of tight structures on the lateral and repair of lax structures on the medial side. Okay, so whereas here you do Hauser's operation, operative reconstruction, which is insertion of patella tendon on tibial tuberosity is shifted medially and downward. Line of pull of patella in quadriceps is also shifted medially. Okay, so around 7 more questions left. No, 3, 4, 5 more pages left. So let's do meniscus injury. Meniscus injury is formed by twisting movement in the semi-flexed knee. Medial meniscus often torn because it is less mobile, as it is fixed to medial collateral ligament. So frequently, because of increase in sporting activity, menisci is succeeded in and nipped. So you suck in and nip it technically, and that's what happens in semi-flexed knee in twisting motion. It will get sucked in and it will get nipped. Okay, so pathoanatomically, meniscus is torn most commonly at the posterior horn. Always it is a avascular structure. Once torn, it never heals. If left unhealed, it will undergo more and more breaking and damage to the cartilage. This is initially the process of osteoarthritis. So osteoarthritis will cause. So type of meniscal tear, you have bucket handle tears, radial tears, anterior horn tears, posterior horn tears and complex tears. You also have lateral tears also. And risk factors, you have discoid meniscus. Unlike normal semilunar shape, it is shaped like a disc, so it's more risky. degenerated meniscus in osteoarthritis, and meniscal cyst. All of these are risk factors. Clinically, you have recurrent episodes of pain, sudden jerk will be there while walking, and swelling will be there. On examination, knee may be swollen, tenderness will be there in the joint line, hidden meniscal tear, you have McMurray's and Apley's test can be performed. So, radiological examination, you can do X-ray, you can do MRI, you can do angiography, and you can do arthroscopy. All of these can be done. So X-ray, you have meniscal tear, no abnormal X-ray findings will be there. You have to do X-ray to rule out any associated bone pathology. So angiography you can do after injecting a radio-opaque dye into the knee. And arthroscopy, thin endoscope can be passed into the joint through an incision 4 to 5 millimeter in diameter. So treatment for acute meniscal tear, if the knee is locked, you manipulate under the general anesthesia and it is immobilized for 2 to 3 weeks. If in cases it's not locked, immobility using knee immobilization is enough. Okay, no need for doing general anesthesia. In chronic meniscal tears, you have to do arthroscope and excise the fragment of meniscus. It's not a useless structure as thought before. Trend is to preserve as much menisci wherever possible by suturing. Arthroscopic menisci suturing. That is the common procedure which we do right now. Then ankle injuries. Ankle is a modified hinge joint. Okay, so socket and ankle mortise is formed by distal articular surface of tibia and fibula, intertwining tibio-fibular ligament and articulating surface of the malleoli. All of these form the ankle. Then superior articulation of surface of talus, and the dome articulates with socket or ankle mortise. So ligaments of the ankle, you have medial collateral ligament, which is the deltoid ligament, and you have lateral collateral ligament. Okay, so medial collateral ligament has strong ligament, has two parts: superficial tibiocalcaneal part and deep tibiotalar part. Then weak ligament is lateral collateral ligament is a weak ligament and it has three parts: anterior talofibular, middle calcaneofibular, and posterior talofibular. Anterior talofibular, middle calcaneofibular, and posterior talofibular. Then there is superficial and deep in the medial. Okay, medial has two, superficial and deep. Lateral has three: anterior talofibular, posterior talofibular, and talocalcaneal. Tibiocalcaneal, tibiotalar. Then forces of the ankles, you have several different forces: normal, inversion, eversion, scapulation, pronation, external rotation, and vertical compression. Then you also have adduction injury, abduction injury, supinator external rotated injury, and prominent external rotation injury, vertical compression injury. There are several types of injuries in the ankle, and they've all been provided here in this table. But clinical features will be common: history of twisting of injury to the ankle, pain and swelling will be there. Oh my god, give me a second. Yeah, my battery was just at 1%. It would have just stopped working if I hadn't plugged it in an emergency manner. Okay, so clinical features: history of twisting of the ankle will be there, pain and swelling will be there, deformed ankle, adducted or abducted with or without rotation can be seen. So deformed ankle will be there, and often the patient is able to explain the exact way the ankle is twisted. So you will have swollen ankle and capitis is noticed if there is a fracture. Radiological examination, you have fracture line, you have disruption of tibiofibular syndesmosis, posterior subluxation of talus is seen, and soft tissue swelling in the absence of fracture indicates a ligament injury. So Lauge-Hansen classification of ankle injury, you have adduction injury, abduction injury, pronation external rotation injury, supination external rotation injury, and vertical compression. So adduction injury, medial malleolus fracture with an oblique fracture line will be there. Talofibular syndesmosis is normal, and lateral side avulsion fractures of lateral malleoli or lateral collateral ligament injury can be seen. Then abduction injury, you have avulsion fracture of the medial malleoli, which may be low, or medial collateral ligament injury can be seen. Talofibular syndesmosis is normal, and fracture of lateral malleoli at the level of ankle modis with communication of its lateral cortex is seen. Then pronation external rotation injury, you have transverse fracture of medial malleolus at the level of ankle modis. The talofibular syndesmosis is damaged, and spiral fracture of the fibula above the level of ankle modis, or no fracture is seen. Supination external rotation injury, transverse fracture of the medial malleolus at the level of ankle modis is seen. The talofibular syndesmosis is normal, and spiral fracture at the lateral malleoli at the level of ankle modis is seen. At the level of ankle modis is seen. Fracture of posterior malleoli may be seen. So spiral fracture at the level, spiral fracture above the level, and fracture of lateral malleoli at the level of ankle modis within communication of its lateral cortex. Whereas here avulsion fracture is avulsion fracture of lateral malleolus or lateral collateral ligament injury may be seen. Medial malleolus fracture with an oblique fracture line is here. Avulsion fracture of medial malleolus and medial collateral ligament may be there. Transverse fracture of again these images you have to remember. Adduction injury, you have one here, one here, one here, and comminuted fracture in the laterally and in abduction. In supination external rotation injury, third malleolus posterior border of the tibia, there will be a fracture, this and this. In pronation external rotation injury, only in pronation external rotational injury is the talofibular syndesmosis is broken. So this occurs, this and here also is seen. And in vertical compression injury, both occurs. It may or may not occur. Medial malleolus, distal end of tibia, and lateral malleolus. Medial malleolus, distal end of tibia, lateral malleolus. All of the fractures may be seen. This one image is enough to do justice. Technically, like if you draw this, you will be able to do whatever you want. So abduction injury, this is a comminuted. Supination external rotation injury, posterior border of the tibia will be fractured. So I think if you draw the images, that's more than enough. This entire table is very difficult to remember. So treatment for fracture without displacement, below knee plaster for 3 to 6 weeks. With displacement, you do oral fixation, open reduction, or internal fixation. Medial malleolus fracture, you do transverse fractures, compression screw, tension band wiring. Oblique fracture, you do compression wires. Avulsion fracture, you do tension band wiring. Then lateral malleolus fracture, transverse fracture, tension band wiring. Spiral fracture, you do compression screws. Comminuted fracture, you do buttressing plating. Fracture of lower third of the fibula, you do 4-hole plate. Every single thing has a new word here. So posterior malleolus involving less than a third, you do no additional treatment. More than a third, you do internal fixation with compression screw. Talofibular syndesmosis disruption, you do stabilization by inserting a long screw from the fibula into the tibia. So tension band wiring may be there, compression screw will be there. In case of medial malleolus, compression screw, tension band wiring, and compression screw avulsion fracture, you also do tension band wiring. Lateral malleolus, you do tension band wiring, compression screw. Comminuted fracture, you do buttressing plating, and fracture of lower third of fibula, you do 4-hole plate. And less than a third of articulating membrane, you do no additional treatment. Internal fixation you do here, and you insert a long screw from fibula into the tibia. Then complications, you have stiffness of ankle. So following immobilization in plaster, there is gravitational edema which hinders mobilization. So prevention, you have limb elevation, crepe bandage, and active toe movements. Osteoarthritis is persistent pain, swelling, and joint stiffness. It is a severe disability. In ankle arthrodesis, there is fusion of talus to tibia. Then you have sprained ankle, which is ligament injury of the ankle. It is caused by inversion injury is lateral collateral ligament sprain. Eversion force is medial collateral ligament sprain. So diagnosis, there is history of twisting injury to the ankle. There is history of pain and swelling over an injured ligament. And weight bearing will lead to excruciating pain. Tenderness is located at the site of the torn ligament. There are maneuvers to identify the injured ligament. Anterior talofibular ligament sprain is inversion of plantar flexed foot occur. Complete lateral collateral ligament sprain, you have inversion in neutral position. Medial collateral ligament sprain, you have eversion in neutral position. You can do to identify the injured ligament. Okay, so then radiological examination. This is a pretty cool glitch. Okay, radiological examination, you can do X-ray of the ankle, AP and lateral, usually it's normal. Stress X-ray in case of severity of pain, and talus tilt more than 20 degrees on forced eversion on eversion, complete tear of lateral collateral ligament if there is a talus tilt on forced eversion or inversion. Then treatment, you provide ice, rest, compression, elevation, rise for 2 to 3 days, and early protective range of motion exercises. Robert Jones fracture is a fracture of base of fifth metacarpal due to pulled exertion by tendon of peroneus brevis muscle. Clinically, it will have pain, swelling, and tenderness at the outer border of foot. Diagnosed by X-ray, treated by below knee walking plaster cast for 3 weeks. March fracture is fatigue fracture of third metatarsal due to long continued repeated stress, particularly from prolonged walking or running, occurring in army fresh recruits committed to walking. Hence the term March fracture. It heals spontaneously. And